is from Professor Rene Chappell. He's currently work as neurointerventional radiologist in Germany in Alfred School Hospital. He have a lot of experience. Please welcome Dr. Rene Chappell. From his talk today, he will talk about his experience in endovascular treatment in basilar aneurysms.
Thank you.
Welcome.
Thank you.
Hello, okay, I just put my microphone on, it's better like this. It's a pleasure to be here and to be able to share these discussions. Definitely, we heard very interesting things. I think, however, that with all the progresses that have been made, I think that nowadays it's not treated by endovascular way, which raises other questions because I don't want to show only the successes. Most treatment do on well, and I think it has no interest if I show you lots of pictures with different devices where everything works fine. So I selected a couple of cases where we had problems and we tried to find a way or could not to solve those problems. So here we go through. The first patient treated already 15 years ago, basilar tip aneurysm, where coiling was achieved and a stent was placed inside each of the PCAs to the basilar, with a result that looked not perfect, but fairly good. And suppose this result was supposed to last, but one of the end of the recanalize, and you see that 6 years later, there is a significant recanalization where the cast of coils completely changed. So flow diverters, we placed our first flow diverter in 2007. They came on the market in 2008. 2011 was the time. So the patient received 1, 2, 3 flow diverters, not all at the same time, which was supposed to clear it. The flow diverters were put to the right PCA. There was no PCOM at time of initial treatment, but here the choice was made for the right side, probably because it was a better accessible side. And here expectation was high that at least the problem would solve. You see, 3 months after the last flow, there was again a very important inflow to the aneurysm. This is flow getting to the aneurysm, which was absolutely not expected. So this shows somehow the limitation where despite increased reduction of flows, this goes together with increased level of anti-aggregation. This is the aspect immediately, this is here the control, and you see this important inflow. And when you check, interestingly, look at this picture here. You see the basilar, the right PCA, but you don't see anymore the left PCA. And remember what I just said before, I can show the pictures initially. Initially, both PCAs came from the basilar. So obviously, now I go back to the pictures here of the you don't see the PCA, but sometimes you see a little bit of flow to the P1 segment left. And what can be the reason for this aneurysm to continue to grow? And obviously, this patient must have developed a PCOM, otherwise we would not see this blinking artery on the left side. And again, if we see now how the vessels are, you see that you have a little bit faintly P1 segment, and here a PCOM that developed that injects the posterior circulation. So some changes in the vessels, and what can explain this aneurysm to grow else than the remaining flow through this P1 segment? And even if this flow is absolutely minimal, this was our hypothesis, and anyway, what to do else in this patient? The aneurysm grew a lot, it's to be compressive, increasing edema, and probably this small leak. So here we chose to go through the PCOM with a microcatheter, and then to go from the PCOM to the P1 segment. Here's the tip of the catheter, and you see between the picture on the left and on the right side that we coiled the origin of the P1 segment, so that this flow, even if faint flow it was only, was not present anymore. So could it be enough to clear the problem? In fact, we expected it, but we were not sure. This is the result. Angiographically, at least on the follow-up, you did not see that there was some remaining flow. And the follow-up on MR showed that this important edema in the brainstem resolved. We have other pictures later on showing that it completely resolved. So here, I wanted to show this patient because point one, flow diverters don't clear all situations. Flow diverters may reduce the flow, but do they completely block the flow? The answer is not necessarily yes. And the most surprising thing here in that patient is that the flow to P1 was just faint. I mean, we could see it here, and then it was gone next second. So it was a very minor flow, but this minor flow kept aneurysm growing in a major way, and putting a couple of coils in the right position enabled to clear the situation. And I guess that this is probably one of the reasons for flow diverters to fail. The rate of failures is evaluated something between 10 and 20%, which anyway is difficult because the way to evaluate is usually and one of the reasons for aneurysm to continue to grow or to have some edema is potentially a minor residual flow. And if you find a way to cut it, then it's nothing inside. Okay, let's switch to next patient. This is a Scandinavian patient where there was a basilar aneurysm at blood. It's a young woman. This aneurysm doesn't look so terrific. It's not giant thrombose, it's a small aneurysm. So she was treated, and as the neck is somehow large, different devices were used to try to hold the coils in place. So here are the coils in place. Here a Picodus device was placed, and then a little bit of thrombus occurred in this procedure. So obviously some ReoPro was given to make sure that no further thrombus occurred. So, and you see that again, very frustrating results because the aneurysm continued to grow. And this is, I think, not so frequent, but we may see this on basilar tip aneurysms. And the result 9 months later showed that the growth of the aneurysm was very significant. I mean, the aneurysm 9 months later is much larger than what it was before. So this patient was treated again in the same team where a T stenting was achieved. So a stent was placed from the right to the basilar, and another stent was placed there. So here was the first stent, here was a second stent in order to make a junction and avoid the stent not being properly opened. So here you may see them, but it's not so easy to see. But look at 6 months later, again, a huge recanalization. So the enthusiasm starts to reduce. And at this point, further treatment was done. Now, an intrasaccular device, a so-called web, or even 2 webs were placed. So webs are super easy to place in, but the level of stability that they give is poor because those webs do compress. There was even a third stent that was placed in the second one. And the immediate result shows stagnation. What is the significance? I don't know, but look at 2 months later. Only 2 months, massive recanalization of this aneurysm. As to be seen also here on this 3D view, where those webs are somewhere here, pushed, compressed to the more distal part of the aneurysm and this important part. And the question is here, what to do, or even how to explain, how can it be, and of course, what are the therapeutic options? And different surgeons were asked. I mean, here again to see the material, he was a piconus. So 4 markers, 1, 2, 3, 4. Here an Elvis stent, the first one. Here is a baby Leo stent. Here is the third stent. So which strategy now? More flow diverters, more coils, more stents, or what? And in fact, if you look at the pictures, and if you look at AP, you don't really have the answer. But I would say looking at the lateral view of this basilar shows the recanalization, the compacted coils. The first device which was placed in order to hold the coils, with a major drawback, potentially, that the stents never opened and never could achieve their function because they were compressed to part of the basilar due to the first device in place. So somehow you could think that, I mean, all this material inside all the material inside the vessels, it's just like too much rubbish inside the river. It cannot solve any problem. And of course, the main problem is the missing opening of the stents. And this is something which is, I believe, where is a tendency to under-evaluate how stents are placed. If you have stents where you only see the distal and the proximal part, it happens very frequently. But probably looking at what is placed in order to have it properly placed. I mean, if there is no material, no stent holding the vessel wall at the neck, then the vessel wall is continuing to distend. So now, of course, how to obtain an expansion of the unexpanded stents, or is it possible? And in fact, here at that point, I saw the patient and I had the option of first trying to go through the right and left stent to force the material with some coronary balloons and materials which are very stiff and quite strong that may help the stents to expand. So after some point, it was possible to open 2 other materials. And finally, here you see that on AP, you don't understand how it looks like, but the lateral view enables to show that now the other part of the lumen was accessed in order to place some kissing flow diverters. But the kissing flow diverters, one is about to be placed. And here at the junction of the basilar tip, there is a missing expansion of the stent. So leaving things like this and deploying the material would make sure that, or at least at high risk for this to thrombose. So it could not be the good solution. We had to take this out to redo some PTAs with coronary balloons and even to place a coronary stent to keep this junction open. Here is a coronary stent, and after which you can see that now the flow diverters open properly. And if both flow diverters are opened, catheter was jailed in the aneurysm, then you can occlude completely up to the entrance of the aneurysm, to the neck. And this is the immediate result. It was a quite long procedure, so ischemic stuff, and I created here with too much material in the vertebral artery some smaller distal infarctions, which she recovered quite well. And here is the 1 week follow-up and the 4 months follow-up. I know now that the 1 year follow-up has been done and it's occluded in a stable way. So the take-home message of this patient here is probably that adding more material cannot be an issue as long as the material initially implanted is not doing its function properly. Okay, let's go now to this other patients, which we saw for this aneurysm. Maybe I can show it again. This is basilar tip aneurysm where there was an endovascular attempt. And the endovascular attempt failed due to stent that was initially it, but you must believe me, the tip of the arrows are the proximal and distal tip of the aneurysm. Proximal and distal tip of the aneurysm, which means that the stent, which was intended to be placed from the right PCA to the basilar, lost its position and now is pointing to the tip of the basilar aneurysm. So this cannot help. So what to do now? Failed embolization 8 days earlier. Should we go on for simple coiling, but improper coiling, not controlling the neck? To add another stent from the left PCA or another stent from the right PCA, or retrieve the stent? Here was a catheterization to the right PCA, and you may see that while navigating with the cat, this induced some pushing against, and here the distal strut of the stent, you may see it here, are against the wall of the aneurysm. This is a very scary image, and definitely bringing the catheter to the stent was not such a good idea. It's still not bleeding, but what to do? Leave it, place another stent. No, finally, the best thing was to retrieve it, and by placing half the stent through the first one, we could retrieve the stent, and here we could take it out. So this first stent was removed, and we could then remove the material. So this is what was done. Here is the first stent in place, while the second one was expanded, holding the first one, and both could be removed this way. So now we come to a more satisfying situation where there is no stent anymore. Wonder, what should we do? Should we stop? Because we're happy to have removed the stent. Should we treat the aneurysm as intended? And I mean, you just took away the stent that was not supposed to be there. So we decided to, the operator here decided to keep on treating, and went to the right PCA as intended initially, started to place one coil, not delivering it, placing the stent. This is not our usual way to do. Usually we have a balloon, but well, the stent was placed, and somehow it is okay, but it seems a bit unstable. And trying to recatheterize to the aneurysm, another problem occurred, that the second stent displaced too. So that's not good. Again, the stent is displaced, so leave it, remove, place the third stent. And here I joined and decided to take the stent out. And the technique we use is to cross with a wire through the stent, and then take a second system with a snare, takes the tip of the wire, close the snare, and this way it's a hook that enables you, you see here is the catheter that has been brought through the stent, the wire is through the snare. Now the snare is, the wire was not inside the snare, so we must reopen the snare. And then we try with the wire to go inside, which will succeed to some point. Okay, and now we check by occluding the snare, we got it. So now we've got here a stable anchoring. And the next step is is it here or? And the next step here is to remove it. And you see by taking both microcatheters, you can pull on the stent and take it out. So here's the second stent that was removed. And now you can check the question again. Stop, flow divert, stent, balloon. And finally, the technique we usually use is to balloon assist coil. And once the coils were in the aneurysm quite stable, then I added a stent, and then we obtained the expected results. So that's here to show that stents may help us, but They don't only help, and sometimes we may get in trouble, but usually there's a way to help ourselves and to find how to control it. Okay, switch to the case number 3, and then there's going to be a fourth one, and then I'm done. Case number 3 is this aneurysm arising at the origin of the basilar, which is filled in by the right VA, by the left VA, and with a specific issue, which is the fact that the diameter of the basilar is much larger than the diameter of both vertebral arteries. The smaller vertebral artery is 2.5, the basilar is 5.5. And how to treat this aneurysm with a flow diverter, which should be the first choice here. Probably it's not so, we have an issue because the material will not hold here very well, and so there's going to be an important discrepancy in diameter. So here I chose to make a kissing stenting, which is to have both stents implanted parallel from the basilar to the right or to the left VA in order to gain sufficient stability here. And here you see that the material, which is U-shape, has been placed like this on the right side, and the left one is about to be placed like this. And this enabled immediate thrombosis, but the results 3 months later still showed a little bit of filling. So it was possible to go down the PCOM in parallel to this and to continue to coil the aneurysm. But I want to show the follow-up 1 year and 2 months later, where the aneurysm is gone. The MR shows that there is no flow. And interestingly, you see that we create 2 completely different channels here in the basilar. So that this here is a channel from the left vertebral artery. And here, this is the one from the right. And the contrast only makes a bit higher distal to this jet to be seen. But a case where I think that the fact to associate flow diverters to make a kissing flow diverter was an important step. Okay, I'm gonna continue with this patient here, who was treated in 2016 for this giant aneurysm. And after doing different occlusion tests, it was seen that he had very good PCOMs and ACOMs. So because of a good circle of Willis, he had a therapeutic surgical occlusion, which went on fine. Patient was doing well. But look at the evolution of the basilar. No? Is there any problem?
No, I'm sorry. I just need to unmute someone. I'm sorry. Okay, go ahead.
Okay, so the basilar in February had a small diameter, but you see that 2 years later, it went from 3 to 10, 12. This is September 18. April 19, it was even larger, getting from 12 to 13. Then in December 19, 17 millimeters, and then even more January. So in March, he had a new angiogram showing that the right side, right ICA was okay. But look at the basilar. And just for you to remember, I showed the basilar initially in 16, and now the basilar in March 2020. What to do? And just for us to remember, he's 16 years old. He's doing perfectly fine. He has no issue. Here is the 3D image where you see that it's not it's a distension of the whole artery. There is no neck or whatever that can be seen. This was in March, and when he came to our institution 2 months later, you see that the aneurysm even continued to grow. this pouch here was added later on. So is flow diverter an option here? I think that it's technically possible to place something from here to there by doing telescopic, but technical success does not mean that the patient will be doing on fine. And whenever the aneurysm is so large, I never saw a patient where treatment was successful, because at some level in between the struts, there's going to be ongoing flow. So from strategy, no treatments is of course not an option. Flow diverter is technically possible, but the chances of success are certainly very low. Test occlusion, stent coils, none of those solutions seems to be so good. However, I started to make a test occlusion. So you see the balloon here. Access to the distal basilar was not an issue. Occlusion of the proximal basilar, which occluded both sides. And by occluding this, we found out that he has definitely a very good ACOM, which takes also in charge of distal posterior circulation with symmetric veins. You see here, the basilar tip is taken in charge. And to do this is not ideal, because you increase the level of flow in the remaining vessel, which may even enlarge. But is there really a good solutions? This patient was referred from a colleague doing open surgery who asked who was able to do a bypass, and he did not find someone. So finally, I occluded here the proximal basilar. And here we are, one side, the other side. And this patient did absolutely well. He had not the faintest clinical impairment. We discharged him a couple of days later. And now we're going to see later how he's been doing. But I'm still, I'm very much afraid, but maybe we can open the debate after the last case I'm going to show on what would have been the ideal management of these patients. Last case I want to show, it's this young girl, young woman. She's 18 years old. She has mild fluctuating symptoms. Here's her MR showing edema, showing something partially thrombosed. And indeed, she has this fusiform, partially thrombosed aneurysm. It may be presumed that the cause of this was at some point a dissection. But this is, of course, only a presumption where the idea was what to do here. Conservative management cannot really be an issue regarding the age and already the edema. Flow diverters from one vertebral artery to the basilar, other, and finally chose to make other. I first thought of reverse while kissing flow diverters, just as I just showed, or parent artery occlusion with or without bypass. And we did a parent artery occlusion, so triple arterial access, occluding both vertebral arteries, and putting her awake with her tube, but still awake, being able to evaluate her. You see a balloon from each vertebral artery, where she was doing perfectly fine. Good clinical tolerance, good angiographic filling of the basilar tip. So we did a parent artery occlusion, and she came awake and she was perfectly well. Here's her CT. So at awakening, normal neurologic examination. She had some pain because we had a bilateral access. So maybe the compressive thing was a bit too strong. And we kept her in ICU to be sure that she had at least a blood pressure of 120 to have enough perfusion through anastomosis. Very anxious, but whether she's anxious or not, I don't know what it changed. She received initially some antiaggregation because we wanted to keep all options open. And 2 days later, she acutely deteriorated and made this bleeding. And this bleeding was evacuated with good surgeons. They made a partial removal, but then it started to swell, and in the end, she passed over. So, is it a hemorrhagic transformation of a small infarction, or what has been the cause? Maybe flow diverter would have been better, but to have her on antiaggregation her whole life is something which also I think in young patients should be avoided. So regardless what we do, all those diseases are really dangerous, and problems are never so far away, and everybody has problems. So I wanted to share these cases with you, and endovascular devices are getting always more fancy, but they of course do not guarantee success. And I think their use must be very controlled, because otherwise they may worsen the situation. Thank you. I'm done.
Okay, Warlix.
Thank you, Professor Rene, for your outstanding and amazing lectures about the endovascular treatment in the basilar aneurysms. Especially also share your tip and techniques in your presentation through your case. So from now on, I would like to give a chance to the floor. If anyone have a questions or you have an idea or experience that you want to share, please feel free from now.
Don't be afraid.
It's amazing.
No comments. I know. No comments or questions from anybody?
I think it's better in the end of the session, because I many days.
Okay.
If you like, no?
Okay. Very good, Warlith.